All right, so what are the effects of cocaine? Pharmacodynamics, what does the drug do to you? Well, as we've mentioned before, cocaine has most of its effect through the sympathetic nervous system. It binds to dopamine transport proteins. The pharmacodynamics of cocaine involve a complex relationship of neurotransmitters. So serotonin and dopamine, and serotonin and norepinephrine. And most extensively studied effect of cocaine on the CNS is the blockade of the dopamine transporter protein. I underlined it again. Let's see if I can do it again. Anyway, dopamine transmitter release during the neural signaling is normally recycled via the transporter. The transporter binds to dopamine and pumps it out of the synaptic cleft into the presynaptic neuron, where it can be put back into the little jars, the vesicles. Cocaine binds tightly to this dopamine transporter, forming a complex that blocks the transporter's function. Thus, the dopamine transporter can no longer perform its reuptake, and the dopamine accumulates in the synaptic cleft. The increased concentration of dopamine in the synapse activates the postsynaptic dopamine receptors, which makes the drug rewarding and promotes compulsive use of cocaine, because the rewarding part is, as I've already said, a misnomer. It makes it important to your survival. Your brain registers cocaine as important to survival because of this dopamine signal. Same as when you eat something that you find satisfying. That part of that satisfying is a dopamine signal telling your brain this is important to survival. Remember where you got this burger or whatever it is that you're eating, and how good it is, so that you can come back and get another one tomorrow, or maybe in an hour. So this is trying to show how the role that cocaine plays changes as the concentration increases. So initially, it inhibits the dopamine transporter, and that's at a small concentration. But you can actually get dopamine cocaine binding as you increase the concentration a little bit more. If you go to 8 times that concentration, you'll actually get the acetylcholine receptor, the nicotinic acetylcholine receptor, inhibited on the same neuron. And then as you increase even further, you get up here to sodium channel blocking, and that's where you die. You do not want these, because your heart will stop. And this little cartoon is trying to show how cocaine can block this transporter, which is trying to take the dopamine back out of the synaptic cleft. It can also, see. So that's actually the dopamine transporter protein, a model of it. And you can see, let's see, dopamine is here, cocaine there, and they both bind to this central cavity in this transporter protein. So that's one of the things that's well worked out. But the more I studied any of these drugs, the more I found out we don't know. Which is to say that now they've come up with a method of testing binding at different concentrations to over 1,000 different receptors. And they found that most drugs interact with most receptors. It's just a matter of at what concentration and what is that actual interaction doing. Sometimes it does nothing. Sometimes it changes how the receptor acts. Sometimes it changes how the channel opens up and allows ions to flow. Sometimes it affects something else that takes a lot longer to find out, like how many receptors there will be on that cell, or some other part of that cell's production of other proteins, all kinds of things. So to be focused in on cocaine binds to this one protein and does this one thing is about as dumb as saying that addiction is about a dopamine pathway in your brain that you find rewarding. Okay, children? The other 50 bajillion systems in your brain are uninvolved in addiction. We have one thing, that is dopamine, and it's this little pathway here, and if we could just ablate that, nobody would be an addict. It's like, wrong, hello. So this is the first thing they found when it comes to cocaine. So this is the thing that I will also be asking you questions about, but it is by no means the only way that cocaine affects what's going on in your brain. So at the same time as affecting dopamine and noradrenaline, it also causes the release of serotonin, or rather, it inhibits the release of serotonin. So that's part of how it keeps you awake. And it inhibits catecholamine reuptake at synapses that use norepinephrine or noradrenaline. And main target organ in the central nervous system and the cardiovascular system, but the effect depends on the dose. It also depends on which other substances are present, the route that you administer it, and what kind of individual susceptibility you have, because some people have a dopamine transporter molecule that is a better molecule at binding to cocaine than others, and the opposite way around, some don't. So at baseline, you have a dopamine signal coming to the nucleus accumbens from the VTA, and you also have this glutamate signal coming to the nucleus accumbens, and that leads to a normal locomotor activity. When you take cocaine and you're not a chronic user, it usually increases this dopamine signal more, which then leads to that necessity signal and some increase in activity. But as you become a more and more chronic user, this glutamate signal becomes more important in telling you that there are stimuli in the environment. So basically, this is an example of conditioning. The bell is ringing, therefore you should start salivating for cocaine instead of just the signal from the dopamine neurons from the VTA. And so that creates the craving, and that's this glutamate signal. And it also predicts relapse. So this is looking at something slightly different than concentration. This is the amount of time, and this is the intensity of the effect. And so this is for smoked. So very little time, on the order of 2 seconds to 10 seconds for effect. and very intense too. And then if you shoot it up, inject it intravenously, it starts in about 10 seconds and it lasts, the maximum effect is about 1,000 seconds. So that's roughly, it's more than 10 minutes. And then for nasal, it starts after about 30 seconds and has about the same intensity though. See, this is a 1, so that's half as intense as the smoked cocaine. And the same for eating it. Takes a lot longer, about 10 minutes for it to even start having an effect, but it ends up with that half as potent effect. Just the same, just over a longer period. And what we already know from studying all of these other substances is that the faster you go from no effect to an intense effect, the more addicting it will be. And also, the more intense that effect is, the more addictive it will be. That's why smoking crack is so much more addictive than even injecting regular cocaine, because the overall effect is about twice as intense, and it occurs in about 1/10 the amount of time.
Is cocaine the only drug that you see with effect with smoking as opposed to in Vegas? Because I know usually it's the other way around. Because whatever, I've never.
Well, cocaine is fairly unique in that there's a whole, club of people that just smoke it and they just smoke crack. So in that way, it is unique. But I think the problem with, if you're looking at things like methamphetamine, the difference between people that shoot it up and people that smoke it, I don't think that there's that big of a difference in terms of intensity for the same dose. But often people that inject methamphetamine have been using it a lot longer, and they inject a much larger dose than anybody that's smoking it. And so that's why they end up, I think, with the much more intense, or at least what they describe as a much more intense sensation from using it. But also, they're administering that dose much more rapidly. When you're smoking meth, usually you have to, take a couple of puffs, and then you take a couple more, and you shoot it, and then, bam, a second, and you're done. And the whole whatever bolus goes straight to your head, and you get the effect. Yeah.
So I like to be doing nothing people when they know some people, but when I hear effect and defect, I don't understand how these depends. And I googled it and I don't understand the how they describe it. It's still like I don't understand.
Well, that is a good point, and I probably use them interchangeably, and they're not. Affect with an A is actually like, how are you doing today? Your affect could be that you're very happy, or you're very sad, or you're bored, or something like that, and that's with an A. The effect is when I administer a medication to you, what effect does it have? And that effect can be a change in your affect, just to keep it confusing. Well, affect is like mood. Effect is how does it change you? Yeah, affect is mood. That's a given, or a way to think of another word for affect. And then effect is, like when you run into a telephone pole with a truck, the effect is that you knock the pole over, usually. If you're lucky. If you're unlucky, you wrap the truck around it and same with your shelf. Not good. But anyway, so some of the effects of amphetamines are all of these: dilated pupils, reduced sleep, constricted blood vessels, blood pressure. Sorry, we're talking about cocaine. My bad. Same difference though. We'll come to the same thing. You're like, oh yeah, they're all the same almost. Reduced appetite, increased heart rate and breathing, anxiety and agitation, and an increase in blood or body temperature rather, as well as blood pressure. Some of the long-term effects though, because don't look at that. It's a little boogie. Well, actually, it's probably necrotic tissue because he's probably still chronically using. And the problem with cocaine is it constricts the blood vessels. And because the mucosal membrane that actually covers the cartilage or the bone in your nose is very thin, when you contract that blood flow, you end up, especially in a chronic user, killing that tissue. Therefore, dead tissue goes away. So this little boogie is probably actually dying tissue. And same up here, dying tissue. And that's why he's got this giant hole in the roof of his mouth. And this one's just a little hole in the roof of their mouth. I've never actually seen this, but I've seen this in patients. And they came to me with a bloody nose and they're like, doctor, why do I keep getting bloody noses? And I'm like, dude, come on, let's be real here.
The doctors know how they know.
Pretty much. If you're using cocaine, you're putting it up your nose, it's really hard to hide. As in felony flakes. Anyone?
No.
You don't have to be that obvious though. I mean, all you have to do is come in complaining of, like a stuffy nose, runny nose, something like that, and you're a cocaine user. It's like, oh my God, really? Yeah, that's because they've killed off that tissue by the vasoconstricting activity of cocaine. They use enough of it that they eventually wore their way through the roof of their mouth. They probably did not come to the doctor regarding this, nor did they come regarding this. They came for something else, maybe a toothache. Yeah, those are common. Or they came because, they're having this problem with tonsillitis or something like that. And the doctor went and took a look and they're like, oh my God.
Got messed up in her eye, and then she had the eye with it. She was still loose. Like she literally had to get her eye shut, so shut, and then she was still there. Don't even matter,
Right. Well, like Miyazawa says, if you're trying to use negative consequences to stop something that's impervious or does not respond to negative consequences, there's a problem. Like negative consequence, eye gone, poof. But addiction doesn't care about negative consequences by definition. It's used despite negative consequences. So the more negative consequences you pile on, oh my, it still had no effect. Really? Can we take away your home too? Oh, and your family and your career? And oh my God, it's still not working. What the? Never mind. Let's take it all. You're like, your freedom. How about that? You end up in jail and you're like, dude, where can I get a bump? Right. Yeah, that could have a very negative effect on your affect being put in jail. But anyway, So the binging cycle that they're describing here is basically that you get that euphoric effect. It inevitably leads to a dysphoric effect where you're feeling like crap, so you take it again. But the problem is that once you've gone around this circle enough times, you can often end up with paranoia and eventually psychosis. So you can end up like a schizophrenic without ever having actual schizophrenia. But you can be like, you know, I saw this pack of wolves going down the street in San Bernardino, and you're like, what the, dude, what are you on? And that's where it comes from. You're like, dude, what are you on? All right. So the local anesthetic effect is that you have these pain receptors out here. That pain signal is a sodium channel, and cocaine is good at blocking that sodium channel. And cocaine is just one of many substances. Most of these other substances are not very good at crossing the blood-brain barrier. So they're very good for using as cut if you can get them cheaply, because people will be numb, but they're horrible as a high. So you'll have cocaine that numbs you very well, but gives you absolutely no high. And people are like, what, am I just tolerant to this stuff? No, it was got with some stupid local anesthetic. Sorry, buddy. Try again. Anyway, so then alcohol also changes the effects for cocaine pretty extensively, in that, like we already mentioned, it changes which metabolites are formed. It reduces the metabolism of the cocaine itself, but it also increases the effect on the cardiovascular system, and can increase the effect of addiction type things like drug seeking. Some people use it specifically for the change in how pleasurable or euphoric they feel when they're on alcohol and use some coke. However, for babies, really bad effects like reducing the cortical thickness, and reinforcement, as in they want more cocaine, of course. And at least in rat models, this coca-ethylene can be lethal, especially when you get enough of it on board. Anyway. So this is just giving a little bit of the timeline, I guess, from the cocaine binge to the crash to the withdrawal. And if you can last that 10 weeks to the eventual extinction and possible abstinence. But in this 1 to 10 week area of withdrawal, a very strong signal in your brain to get more, which of course would be relapse. But so the takeaway here is, if you're going to go into treatment for cocaine, please do it for at least 10 weeks, or join NA right away. And a lot of people don't do either, and so they relapse. So if somebody's taking a bunch of cocaine and they start acting bizarre, erratic, or violently, they may be experiencing toxicity from it, especially if they start getting the tremors, shakes. Vertigo would be obviously not being able to stand up, feeling like you're dizzy, muscle twitches. Paranoia and psychosis, unfortunately, can be a chronic effect as well as an acute effect. But often, if they start experiencing the chest pain, along with like neck pain or shoulder pain, they may be having a problem with vasoconstriction to their heart. And that's one of the main ways that people end up overdosing from cocaine, is through a heart attack. And regular cocaine use also starts changing the blood vessels of the brain, and can make it more likely that you'll have either type, the bleeding stroke or the block stroke. And just like a bloody nose, you can also get a bloody brain, the cerebral hemorrhage. Oops.
Is that what, like, when the people get, oh my gosh, what's it called? I forgot, no, it's called something that when they die, like, just, like, cause, my uncle was in the shower and he just died. And they said he had a,
Embolism?
Yeah, embolism.
Yeah.
Is that what that is? Was he like,
No. Or at least somewhere around a key. Yes, absolutely. So it's not, yeah, it's not normal, but certainly you do not have to have drugs involved to get an embolism or have, that tragic brain bleed that can follow when that thing pops and people drop dead. Well, he may have been, but it may not have been involved in his death.
Like, it was just sudden, that's like your brain bleeds, right?
Mm-hmm. Yeah. And it definitely, yeah, people go from howdy to dead in seconds. But it's not entirely clear whether cocaine produces neurotoxicity, that is, directly kills neurons. There are broad claims that amphetamines, especially methamphetamine, causes neurotoxicity.
It kills neurons?
It's not clear whether cocaine does, but meth does, supposedly. So signs of overdose can include seizures, a lack of circulation, unconsciousness, chest pain, trouble breathing, vomiting, and of course the foaming at the mouth kind of thing, where it's not clear whether they're actually breathing in or throwing up or ingesting or anything. It's just like, what the beep? But anyway, so you try to clear their airway and get them on their side, so if they do throw up, they don't ingest it or breathe it in. And then this is looking at some of the acute effects of cocaine and then some of the chronic effects of cocaine on your cardiovascular system. The acute effects can be things like coronary spasm, which is probably what killed Len Bias. Some of the chronic effects are the dilated and hypertrophic cardiomyopathy. The reason I say that name is because he was a great basketball player that was like the #1 draft pick. And when I was in high school, he dropped dead of cocaine, and it wasn't even an overdose.
What's a coronary
Spasm
coronary
are the blood vessels that go to your heart, and when they spasm, they're closed off.
on the court?
I don't think he was playing a game, but I think he was playing ball. Yeah, and I was really looking forward to watching him play, and then boom, the next thing you know, the next day, like, well, it wasn't the next day, but it was very close to when he got drafted that he was dead, and you're like, what the beep?
Was it like in the media that he drug used?
No, no.
Oh, maybe.
Right? Like everybody was doing it, so he went to a party.
They say there's a lot of potential in a where they bury people at, that there's a lot of potential in graveyards. It's sad.
Are you saying that there's a lot of drugs in it? Oh. Yeah, it is sad how many years are shaved off of people's lives because of drug overdoses. It's not like, you know, dying in your old age because of, I don't know, Alzheimer's or something, you know, it takes a few years off versus this is more than half their life. So this is just looking at cocaine involved overdoses. Of course, there's a lot of opiates involved along with the cocaine. So cocaine plus any opioid is here in green, and this is not the most recent data. Cocaine without any opioid is in light green, so the actual upswing is very slight for cocaine use versus cocaine plus an opioid. And this is cocaine and fentanyl basically in yellow, this one. Similar information. With opioids, all cocaine involved deaths, and without opioids, all cocaine involved deaths here, but you can see that the actual upswing is not just cocaine, it's almost always cocaine with an opioid in the 2015 and on. So what do amphetamines do? Well, they do similar things. They do everything cocaine does basically, and then some. The only thing they don't do is they don't block those peripheral nociceptors. So you don't get numb from taking amphetamine. The primary molecular targets are plasma membrane transporters. Amphetamines behave as a competitive substrate for the reuptake of norepinephrine. So it acts on the norepinephrine transporter, as well as this DAT, which was the dopamine transporter that we were talking about with cocaine, as well as the serotonin transporter. So amphetamine acts on the same one as cocaine, but also acts on the one for serotonin and norepinephrine. It's the overachiever. You know, you thought Coke was good, try meth. Ooh, okay, let's not do that. So these transporters normally work to take the extracellular monoamines out of the synaptic cleft and return them. So the main activity of these proteins is to terminate the neurotransmission at that synapse. Cross affinity between amphetamines and neurotransmitters contribute to generating the quite selective storage of amphetamine within specific neurons. So what that's basically saying is that, oops, instead of transmitting, say, dopamine or norepinephrine or serotonin, probably lesser effect on serotonin, but instead of storing dopamine or norepinephrine, it's accidentally storing amphetamine to be subsequently released the next time there's a synaptic transmission right there. So it's going to actually send amphetamines out instead of neurotransmitter. So that's another way that amphetamines have the same effect, quotes, as cocaine, but then more. They're also acting as the neurotransmitters themselves. And this is stating that basically the dopamine and norepinephrine affinity is 500 times that of the serotonin. So at low doses, the predominant activity is to bind the dopamine and norepinephrine transmitters. But as you increase the dose, like 500 times that dose, then it'll start also binding to the serotonin one. And like we showed before, amphetamines are similar to dopamine, norepinephrine, and epinephrine, but not that similar to serotonin. And that's probably why this 500 times difference in affinity. And then it does bind to the norepinephrine about 10 times better than the dopamine. And not only does it affect this transporter protein, but amphetamines also promote the release of norepinephrine and impair the reuptake. So where cocaine was just acting on this one transporter that affects the reuptake of dopamine, amphetamines both promote the release of norepinephrine and block the reuptake of norepinephrine. So this is looking at the differences between concentration and the effect of amphetamine. So initially, it's going to have its effect primarily on this norepinephrine reuptake protein. As you increase the concentration, it will have an effect on the dopamine as well as the norepinephrine. And then as you increase the concentration even further, it will add the serotonin. And it has these other intracellular effects as well. So it's just an overachiever all around. Yeah, you could say that. So here's methamphetamine. Normally, the dopamine would be moved by this protein into the synaptic cleft, but meth actually reverses this protein and causes the meth to be moved into the neuron and then moved into the vesicle so that the meth can be released along with the dopamine from the vesicle the next time this neuron fires. And meth also blocks this DAT, which is trying to move the dopamine back into the cell and turn off the signal. So yeah, I don't know. You can read this, I guess, if you want. But basically what it's saying is that there are specific parts of the reticular nuclei, parts of the brainstem that affect things like locomotion, addiction, craving, aggressiveness, anorexia, which is not eating, psychosis, depression, cognitive impairment. All of these effects or behaviors can be expressed because of changes in how the amphetamine produces these changes in your brain. And those are specifically the neuroplasticity type effects on the short term. Things like heart rate, hypertension, hyperthermia, excitation, alertness, and wakefulness have to do with the brainstem. And these are the various nuclei in your brainstem and which neurotransmitters they primarily use. So you've got acetylcholine in red, serotonin in yellow, and our ever-loving dopamine here in the violet color. And you can see that this A10 is part of the VTA. That's the culprit. Dr. Evil lives right there. I'm just kidding. But there's a whole bunch of them. and they each regulate something different. And we're not going to get into exactly which ones do what, but suffice it to say that they control all of these things, like the intensity of euphoria, the heart rate, hypertension, your body temperature, how excited or unexcited you are, how alert you are, and how awake you are. And those areas of the brainstem then feed up into this portion, which is like the switching network for your brain. And then that can send radiation of neurotransmitter to the rest of the brain, basically. But the limbic portion here is what's affecting emotion, learning, memory, reward, and addiction. The hypothalamus is looking at regulating food intake, your temperature, and your arousal level. And then the prefrontal cortex is where you do your planning, your cognition, and thinking. Right. Yeah, we know there's a lot of side effects and consequences of amphetamine abuse. Some are short-term, some are long-term, and some can be signs of overdose. So the cardiac rhythm abnormalities are the ones that are often the fatal ones. So like ventricular fibrillation is relatively immediately fatal. And that's often how amphetamines kill, is somebody has a susceptibility or some predisposing factors to developing a cardiac arrhythmia, like maybe they have heart disease and they have most of the coronary artery circulation already blocked off, and then they take some amphetamines that increase the demand for blood throughout their body, and their cardiac or their coronary arteries can't keep up. They will often end up in an arrhythmia. If that's ventricular, they die. So I would say less often, overdose can lead to confusion, delirium, troubles balancing, loss of consciousness, and coma. And you guys can read through the list. I don't think it's that surprising as to what the short and long-term side effects are. And then this is just talking about how dose affects what the effects will be, of course. And one of the earliest effects on your body is an increase in your heart rate, followed by things like blood pressure increase and appetite decrease and breathing rate increase. And things in your brain, like what you're thinking, your fatigue is one of the first things to go away. I love how it says increased confidence. I would say it's increased ephitol. You just don't care. It's not really about confidence anymore when you don't care. And an increased feeling of alertness, restlessness, irritability, some people, fearfulness. This is a huge one. Distrust of people. And I just crossed it out. Oops. But anyway, yeah, chronic amphetamine users don't trust anyone, including themselves. And so here's looking at how much amphetamine somebody ended up taking over what period of days that actually resulted in psychosis, and showing that it's very much dependent on the individual, that there's no one spot where psychosis for all of these people in this group or in this study ended up developing the psychosis. Some people it was in 1 day, some people in 2 or 3 days, some in 4, some in 5, but they all developed it eventually is the key. Yes, it certainly can. But I think it also has something to do with the ability to determine what's real and what's not. And absolutely, you can induce psychosis simply by depriving somebody of sleep. Usually it requires work, and that's why it's called Chinese torture. But you have to physically often wake somebody up to keep them up long enough. It's not like you can just sit there and just focus. I'm just gonna focus. I'm gonna stay up. I'm gonna stay up. I'm gonna stay up. No, the big bowl of ice water to the face. Yes, that helps, and a whole lot of other things to help keep you awake that length of time. But yeah, you certainly can induce the psychosis. But I don't think for most people it would be that they've been awake this entire time. It's just that they've been taking amphetamines, and eventually they developed a psychosis.
I'm sure a personal story real quick.
Sure.
Okay. I mean, I'm just to be transparent. I used meth for a very long time, and I personally, after about 2 or 3 years of use, I didn't go into a psychosis until about maybe year 3. And I actually really saw things in my house that I thought, I was just like her. I thought these dust bunnies were aliens. And I thought it was real. I can look back at it now because I've been cleaning sober for almost going on 4 years. I really thought that it was real. In my head, I thought that it was real. I can't explain it any other way. I look back at it, and it was crazy, but it really does trip with your mind to make you think.
Like that so much.
I don't think so. I don't, because I did sleep, and it wasn't like the onset immediately, because when I first started using, I would go without sleeping, but then after using for a long time, I was able to sleep, and that's when the psychosis really came on, was when I had been using for multiple years. So I don't know, I just find it interesting because it's so true. I really thought things that weren't there. And I was like, yeah. I don't know, I just wanted to share that.
Well, and I've read that the picking that people do is often because of psychosis. And part of that is that they feel an itching or a tingling underneath their skin. It feels like something's crawling under there, but it's not just that, because if you or I felt that, none of us would be taking a fingernail and trying to find the bug. Well, I've heard all kinds of fun stuff, like people that have thought something was in their neck, so they used bleach on their neck to the point where the skin came off, and then they use their fingernail to go in there and their other instruments to try and pull stuff out of their neck. It's freaking crazy.
But they have this thing you have to do with patients being crazy about this. Like, is there certain like the doctors have to do it?
Well, are you asking if we're required to 5150 somebody? Yes, we are.
But,
well, that's the weird thing about schizophrenia and psychosis, isn't it? Yes, we have a giant sticker we put on the front of your car. Fucked up. Parentheses meth. Well, it's not so much at the hospital. It's more like the people often end up having some kind of interaction with law enforcement, and they get a referral because it's not necessarily that, I think this happens less and less here because they just don't give a shit, or because they're worried about, CYA, but they're more worried about being shot at than how somebody's mental health. But you do end up in, like, not Patton, but there are these lockup facilities for mental health where you can end up if you're frankly crazy, psychotic. And like this is saying, there's a big difference between acute meth psychosis and chronic meth psychosis. And there's also a difference between each of those and schizophrenia. But to the casual observer, there's not much difference between any of them. The difference, or the biggest difference between acute and chronic, is that hallucinations are not as severe in the chronic psychosis as they are in the acute, but the hallucinations are actually more severe than in schizophrenia. If you can believe that, where you've got a condition that's characterized by hallucinations. You're like, no, wait, chronic meth users are more psychotic than schizophrenics. What? Anyway. Well, sometimes you do, but I agree. It's far more common in a meth user. And the negative symptoms, though, the things like depression and the, psychomotor depression compared to acute meth psychosis, but it's not as severe as schizophrenia. So that's the big difference between these, is that these people get a lot more depressed than the chronic meth psychotic. These people just show up with florid hallucinations. They've got stuff coming out of their neck. They got bugs crawling under their skin. They've got, aliens chasing them. You name it, they've got it. Yeah, the pavement actually walks when they walk. Things like that. Really trippy stuff. No, we'll get to PCP a little bit, but no. Right? Let's try it together. Maybe it's better. No, but PCP has its own little carve out in psychosis, in that it's easier to become psychotic with PCP because usually it's a part of intoxication rather than with meth, where it takes a while. You become floridly psychotic as soon as you get high on PCP. And thus you have people going into to a restaurant naked to get ice cubes to put up their butt because they're too hot on PCP. That's PCP. It's crazy shit, like you would never seen. I'm just kidding.
No, it's funny because I work in a restaurant. Sometimes people come in and function.
Yeah, well, around here.
You just want to save everyone. And so, yeah.
Right. Well, it's true. You have to save yourself before you can save anybody else. But
we didn't bother him because we didn't want to. We didn't want to be rude. And he was literally just standing up.
Wow. Was he a nodder?
And it was kind of, and customers were coming in and out, but we just let him know we wanted to be rude. Yeah.
Well, you probably didn't want to wake him up either and get him pissed off and be like, dude, that was such a good high and you fucked it up and now I'm gonna fuck you up. Excuse my effing language, but sometimes I divulge into the French or whatever. But anyway, so at least in rats, methamphetamine kills neurons, and this is how it can create those reactive oxygen species we were talking about and nitrogen species, which causes the batteries, mitochondria of the neuron, to die, and that leads to the neurons dying. But it also creates this butyric acid, and that is not a good acid for mitochondria either, and can lead to the mitochondria dying and the neuron dying. What I haven't seen are the MRIs or PET scans or whatever of chronic meth users showing that there is radical reduction in or atrophy of the brain. Like I was showing you with alcohol, that's a known thing for chronic alcoholics. Their brain gets smaller and smaller, so they got less to work with. I have yet to see that for methamphetamine. I'm not saying it doesn't happen. Certainly it happens in rats. I don't know whether it happens in people. I couldn't find it. They claim it does. So they claim that there's brain injury. And I imagine with any of these things, if you end up with insufficient oxygen or insufficient nutrients, methamphetamine users are the classic is they show up and there's a bag of bones, that those things are going to have a negative impact on all of your organs, including your brain. So it wouldn't surprise me if there is brain injury. I'm just not sure if it leads to the kind of neuron death that happens with some of these drugs. Like the classic one for killing brain cells are inhalants. That happens rapidly. We're not talking about, you have to use alcohol for 40 years to end up reducing the volume of your brain. You use inhalants a few times and it's already starting to shrink. But there certainly are circumstances that are set up here, like production of ammonia, systemic inflammation signals, reduced oxygen supply, that could all cause brain injury. And I think this is from the, there was a website I was looking at from Duke University about the effects of amphetamines and specifically methamphetamine. And they were saying that it does lead to a reduction in the volume of this corpus callosum, which is the part that connects the two sides of your brain. And it can have an effect on the frontal cortex. And the fun thing about all of this, of course, is when you're talking about any of these illegal drugs, is what else is it cut with? Or what was it produced with, and how much of the solvent is still present? Because when I just said solvents, I was thinking, oh my God, every one of these drugs, to extract it, usually it is a solvent. And if you've got some whack job instead of an actual pharmaceutical company that's making it, and they didn't get rid of all the solvent, you're huffing solvent every time you use the drug. Whatever they're using, ether often is a solvent. Gasoline is a great organic solvent. Well, true, and that's what I mean. They use a lot of ugly things, like an organic solvent that's used in preparing meth is that not so much rat poison, but any organic solvent, but often it's that camp fuel. it's like kerosene kind of. That's a solvent that they could use as an organic solvent. Another one that I read an article about anyway was that they were using the seems kind of expensive, but hornet spray, pesticides like roach spray, hornet spray, whatever, the organic solvent in that to prepare some meth. And I can only imagine how good that was for them. This is vitamin filled. It kills roaches. You're like, dude, if it kills roaches, don't touch it, because nothing kills roaches. Anyway, so then drugs that cause seizures are plentiful, but some drugs during acute intoxication, like cocaine and amphetamines, can cause seizures. Of course, others are like ecstasy, PCP, ketamine, and alcohol in withdrawal, where can cause seizures. Benzodiazepines, which are part of the sedatives, and hypnotics can cause seizures. But this is just to try and draw all that together for you, to give you a list of stuff that can cause lots of jumping around. And once again, for amphetamines, having alcohol on board changes everything. It changes the pharmacokinetics, it changes the cardiovascular effects, CNS effects, and prenatal effects. So when it comes to your heart rate, it just increases, or cardiovascular effects rather, it just increases the effect. But that can all lead to an increased consumption of oxygen or demand for oxygen. And if you have predisposing factors like heart disease, diabetes, something like that, and you have alcohol and meth on board, that increased oxygen consumption will potentially lead to a heart attack. The decreased metabolism and excretion of the meth can be a, what should we say, an economic benefit. You stay high longer. Levels of meth and its active metabolites are increased. And the effects on the prenatal or the fetus are increased. So amphetamine withdrawal usually is worst in the first week. And that's when, the craving is the worst, the depression is the worst. I would say for chronic methamphetamine users, usually the first week they're not even awake. So that might actually be a misnomer to say it's the worst, because if you sleep through the first week, the second week is really going to suck. But either way, it's not a quick process is the key. And the post-acute withdrawal syndrome, or pause, is certainly present. It can also be present for a number of other things like heroin, but that includes things like depression. And this is over a period of 3 to 4 months, or 3 to 6 months rather, after last using, feeling tired, having troubles either getting to sleep, staying asleep, or getting up, and then just feeling like nothing is fun. Everything sucks. And putting on some weight. And then when it comes to the overdose, the toxic effect of amphetamines is different than cocaine, and that's the one way in which I guess amphetamines are a little bit better. It takes a lot more to overdose, and it does not stop sodium channels, so it doesn't stop your heart. And fatalities have been reported for people that ingested as little as, although that's quite a bit, 1.3 milligrams per kilogram. If the person weighs 100 kilograms, that's 130 milligrams. So that's a bit. But as you are a chronic user, your tolerance develops. So often, chronic users use a gram at a time, sometimes up to 5 grams in a day. So that's how much you put into your cc's. I mean, I've seen this go into a gram in a cc. So 5 grams would just be shooting up 5 times in a day. And then this is looking at psychostimulants. So it includes methamphetamine, but it's certainly not only methamphetamine, because the actual number of people who are using meth and overdose, like I was saying, is relatively low compared to cocaine. Cocaine is much easier to overdose on. And this is abusable psychostimulants with fentanyl. This is abusable with any opioid, and then the number without any opioid is this light green. So overall, they say that psychostimulants were involved in this many, so obviously on the increase. But how many of those are actually meth? It's hard to say. And this is, once again, looking at with opioids on this side, without on this side. So this is the psychostimulant involved in the death without a synthetic opioid, and this is psychostimulant involved with death without any opioids. And then over here you have with opioids. So unfortunately, they're both on the rise. Unlike the other one, where the number of people that were dying of cocaine alone was relatively stable, and the number of people that were dying of combination of an opioid and cocaine was rapidly increasing, here you have them both increasing. But the number of people using a psychostimulant that were dying and had any opioid, you can see it was almost zero up until about 2012. And I think part of the reason for that is that often people who use amphetamines don't use opioids because they're kind of antithetical. It's like, if you're going to get high using an upper, why would you use a downer at the same time? That's such a downer. And then overdose death rates, Las Vegas, baby. That's where it's at, but also California, and we'll get to that a little bit later, but especially in the Los Angeles area, anywhere down here along the Mexican border, you get a lot of use. Yes, there's an awful lot of meth in Hawaii and in Alaska, of all places. And then look over here, West Virginia, known for its opioid overdoses, but it's also doing pretty good when it comes to meth. And remember, it's a dry state, no alcohol. So you got to get creative in West Virginia, baby. Oh, Desfan is Arizona. This is New Mexico. I believe this is, what is this, Oklahoma or something? Yeah, Oklahoma. Oh my God. I was going to say a joke and I won't. That's bad. Anyway, so you can draw a line almost along the Mississippi River and cut the country into meth versus fentanyl in the number of overdoses that are predominant in that area. But my guess is that that is highly affected by two things. One is what did the users that came before you use, and the other is how easy it is and who's bringing in, what gang lives in your hood and what are they bringing in. And it's, well, like I was saying, along the Mexican border, it's primarily meth. And over here, it's easier to get the extremely potent and relatively small volume fentanyl. And also on the East Coast, that's where, all the heroin used to be. So people over here are looking for opioids. And over here, we've got too much sunshine. I think that's what it is. Sunshine-induced psychosis. Anyway, so this is looking at LA County from 2008 to 2017, and they're saying some pretty bad things, like that there's a 7 times increase in the number of people dying from meth, and there's a 5 times increase in the number of people dying from drugs overall. So meth is trying to catch up, but that's a lot of people dying either way you look at it.